Welcome everyone to the second day of the APACI Respiratory Diseases Workshop. I welcome you all again here today, and we've got a really interesting day planned for you. The first session is in fact going to be some debating sessions, and we've got both the for and the against in these two sessions by highly reputable professionals in their field. So it's going to be very, very interesting. But before we get into that, there are some housekeeping things that I need to mention to you. As most of you would know if you were here yesterday, there is a feedback form which we need you to complete by the end of the meeting, and that's in the lobby. If you're in the lobby, you can visit the Kipler stall, and there's some interactive media associated with that. And Kipler are involved in the last session, which is a quiz, which is going to be very, very interesting, and we're looking forward to that. And if you have any questions during the meeting that you would like given to the or taken to the Q&A, please use the question tab in the auditorium. So with the first session, the first thing you're going to see is a poll. And before I introduce the chair of this first session, the poll is going to ask you the question: molecular diagnostics should be used for patients who present with a moderate to severe viral infection. Are you for or against? Now, we're not going to show the result of this now, and after the two speakers have given their arguments, we're going to ask the question again to see whether you've changed your opinion. We will then have the Q&A, and at the end of the Q&A, we're going to show the results of these polls to see whether there's been any shift in the participants' opinions on these important issues. So now it gives me great pleasure to introduce Professor Hisham Unzil, who is the Assistant Professor at the Medical School in Rabat and head of the Virology Department at the National Institute of Hygiene at the Ministry of Health in Morocco. In 2002, he was appointed as a postdoctoral fellow at the Neurovirology Laboratory at the Atomic Energy Commission in Fontenay-aux-Roses in France before joining the National Institute of Hygiene. And for over a decade, Professor Unzil's research focused on communicable diseases surveillance, infectious disease epidemiology, virological diagnosis strategies, rapid testing and evaluations of POC or point-of-care technologies, and laboratory capacity building and settlement of the national laboratory networks. Highly qualified for the session that we're about to go into. And as a result of the work he was doing, he was assigned as a member of the National Authorization Commission for Laboratory Reagents at the Ministry of Health, and served on a number of panels dealing with different issues of epidemiology, disease surveillance, and public health policies. Currently, he is serving as a key coordinator of the virological surveillance of SARS-CoV-2 influenza and respiratory viruses in Morocco in the framework of the Pandemic Influenza Preparedness Program with support of the WHO and CDC. He is also the lead virologist for the management of several public health programs in HIV, hepatitis, polio, and measles. Professor Hisham, welcome. I look forward to hearing from you.
Thank you very much, Dr. Kim. It's a great pleasure to be here with you. And I thank the APACI and also the MENA ISN for inviting me to moderate this session. I had the pleasure to be yesterday with you for the first session, which was regarding the management and the vaccination of respiratory diseases. I think the second day comes to accomplish what have been said yesterday regarding from the perspective of laboratory practices. I think today we have two great scientists, two panelists will, and we will have a debate regarding the role of molecular diagnosis in current clinical practice, knowing that one of the goal of molecular diagnosis is integration into the clinical team to provide value-added experience and personalized information for care patient. So I think that it's the choosing this this item was great from organizers, knowing that one of the emergent trends in healthcare is precision in medicine and diagnosis, whereby laboratory testing enables tailored diagnosis and treatment. I have the pleasure to launch the debate with Dr. Gupta, Debkishore, who is a direct, who is Dr. Debkishore Gupta is a former postdoctoral fellow in molecular microbiology at the University of in Florida, and fellow. He was a fellowship in clinical microbiology and infectious diseases. He's a postgraduate diploma in infectious disease. Actually, he's director of medical affairs in CFAID and consultant head of clinical microbiology and infectious diseases, infection control, quality and clinical excellence, and member of the faculty at the NB Microbiology and founder of ISIS WB chapter. He participates in organizing several events, and he was the joint secretary of HISICON in 2019 and advisor to state government on dengue, COVID-19, and also member of the faculty of CAHU. I give the floor to Dr. Gupta for his speech, and the floor is yours. Thank you.
Hello. So the topic of today's debate is the role of molecular diagnostics in current clinical practice. Yes, there is an argument whether molecular diagnostics should be used for patients who present with moderate to severe viral infections, and I will speak in favor of molecular diagnostics. So I have few slides. I'll share my screen. Well, we know the role of molecular diagnostics, especially even every common people have come to know about the role of RT-PCR during this COVID-19 pandemic and the impact it had in curbing the spread of infections for COVID-19 pandemic in last 2-3 years time. So it's not new anymore, and we appreciate the high sensitivity and specificity of nucleic acid amplification tests, which are capable of detecting one or more viruses, and it has become a gold standard in clinical virology now. So that's my starting statement, that this is a gold standard, and there are multiple references for in clinical virology that the role, the impact this nucleic acid amplification tests, molecular diagnostics have in treating, in diagnosing virology or respiratory viral infections is immense. In the setting of ongoing community transmission, testing all symptomatic individuals is optimal for informing isolation practices, contact tracing, and evaluating the changing epidemiology. I admit that we have entered a different phase of pandemic where people are not going for testing and isolating as appropriately. But if you look back 1 or 1.5 years back, so this was essential. And that time the virus was more virulent. There's not enough knowledge in that treatment part, and also a lot of vaccines were not available. So considering that time, you understand how important the role of molecular diagnostics was, because it is only possible that stopping community transmission if you diagnose a patient correctly. So needless to say, I mean, this is actually, I can say, written on stone that the impact of molecular diagnostics in, at least in respiratory viral infections, cannot be denied. Well, I'll capture a few slides from Infectious Disease Society of America, IDSA. As a formality, I'll just read out the role of molecular testing, rapid molecular testing for influenza has the potential to reduce unnecessary antibiotic use. Yes, if you know that this is flu, if you know that this is some other viral infections, obviously you will not give antibiotics. And what we are seeing in a lot of countries, including developing countries, even the pharmacists are giving prescriptions sitting at the pharmacy. You go to any chemist shop, you'll get an antibiotic, and when you come to a doctor, the antibiotic use is huge. So this can actually reduce this unnecessary antibiotic use and help in stewardship at the community level. Improve antivirals prescribing. Yes, I mean, we have seen many a times oseltamivir, which is available in our country, is randomly abused, randomly used, prescribed. But do all patients require antivirals? So that decision making is feasible only when you know the etiology of the illness. If it is viral, if it is patient is in some risk category, definitely you can go ahead and prescribe antivirals, but antivirals are not to be given empirically to each and every patient. Limit additional ancillary testing. So if you look into this overall diagnostic journey of any respiratory infection, you'll see that there are a lot of trials and error phases. So initially, patients do not come to the hospital; they go to the clinic. I mean, the chemist shop. They have something, self-medication, maybe some antibiotic. Then they come to the hospital. They are given some blood test, and by this time, you lose the golden time of starting antiviral if it is required, maybe some another round of antibiotic. So everything becomes very, very messy. And if you actually take into account all these additional uh, struggles, additional uh, testing, uh, going to and fro to a clinic, to a chemist shop, everything, you'll understand, I mean, there's definitely a huge need of upfront molecular testing when a patient presents so with symptoms of respiratory viral infections. Obviously, this can shorten hospital or emergency department length of stay. And needless to say, I mean, the sooner you diagnose a patient as having viral infections, you can quickly isolate that patient, or at least if the patient is not having any viral infection, you can free that bed, and at least you can free one isolation room. Basically, your decision making becomes very, very prompt. And also, shortening hospital stay, that's also very important. I mean, the sooner you diagnose, then it becomes very easy, and you can actually, prevent a lot of complications very timely. And reduction of hospital stay has got a huge financial benefit, not only to the patient, but also towards the hospital, because the length of stay reduces and you free up your hospital beds for other patients. And at the same time, you can also limit transmission. If at all a patient presents with flu or SARS-CoV-2 or any other infection, you diagnose the patient very, very quickly, isolate the patient, you can actually stop spreading the infection to another patient. And who knows, if the patient is having a lot of comorbidity, that patient can also die. So it optimizes infection control practices. Definitely these isolation practices, contact precautions practices, barrier nursing, even engineering controls. So everything's are closely linked with this decision making. So if you look into this aspect, you can see the journey starts from the diagnosis, and the diagnosis is solely dependent on molecular testing. So a patient presents, so based on the molecular testing, a lot of decisions take place in the hospital regarding the patient stay in the hospital and trans transportation to another part of the hospital and segregating the patient from other patients. So many decisions are actually very, very closely interlinked. Coming to the cost effectiveness, I'm sure my next speaker will speak against molecular testing. We'll talk that these tests are actually costly. So, I mean, definitely, the upfront cost or the apparent cost may be higher, but if you look into the cost to the solution, then your perception will change. Molecular testing for multiple respiratory viruses simultaneously may also be more cost effective than traditional antigen or culture based methods from a laboratory perspective, especially given a certain threshold of disease prevalence. So there are evidences, there are publications, there are data that if you can detect multiple respiratory viruses at the same time, this is going to be cost effective. Whereas you spend time, you do some trial and error, you send a battery of tests today, few tests tomorrow, and at the same time continue with antibiotics. So overall, if you look into this overall financial aspect, so upfront molecular testing, especially when you test multiple respiratory viruses, becomes actually cheaper. The modeling, infectious disease modeling, it suggests that an approach of testing and then treating is generally preferred to empiric anti-influenza treatment during periods of moderate disease prevalence or when risk of severe disease is moderate to high. So yes, we have scientific modeling data to support that this is actually cost effective. So this is a conceptual hierarchical model of efficacy for molecular diagnostics. This is adapted with permission. So if you look into this technical efficacy and how this is linked with diagnostic accuracy efficiency, you see this. There is resource requirements, there is time to result advantage, there's advantage in sensitivity and specificity, because for certain infections, you cannot just afford to miss a patient. So you should have something very, very sensitive, but at the same time, it should be specific as well. Otherwise, if there are a lot of false positives, you are in trouble, you waste important resources, because you have to understand that resources are limited. Positive and negative predictive values. Again, this is of immense value here, because negative predictive values, especially, I mean, if the molecular test result is negative, is it really negative? So if the NPV is very high, you can be rest assured that, well, this infection is ruled out. So this kind of data, this kind of informations are pivotal in taking your further calls in terms of management. So coming to diagnostic decision efficacy, it's helpful in making diagnosis. Certainly you come to a diagnosis very, very soon, and it changes probabilities in differential diagnosis. You have maybe 3, 4 differential diagnosis, especially when you have local data of circulating different viral infections. So you do not know whether this patient is having COVID or flu or RSV or some other, new viral infection. So this narrowing down in differential diagnosis is very, very critical as far as patient management is concerned, because you have to understand that treatment modalities are different. Certainly, flu management will be different from SARS-CoV-2 management rather than some other infections, and as a matter of fact, even bacterial infections. So you need to diagnose your, the viral etiology, and likewise, you can narrow down, you can streamline your antiviral, or rather your entire treatment regimen. So today is a day of precision medicine, and you have to narrow it down as early as possible, because time is important. For therapeutic efficacy, yes, therapy change after testing. So once you come to a diagnosis, you can change your therapy. If you are within the golden period of time of, say, around 48 hours, and the patient is eligible, definitely you can start oseltamivir, which is available in our country. But again, I'm reiterating, there is a golden period of time this oseltamivir works. So timely diagnosis is extremely important because other than that, your oseltamivir prescription is going to be completely empiric, and you end up giving oseltamivir to many patients, and where you do not know, I mean, this abuse of oseltamivir is going, what damage is going to cause to the antivirus, and especially when we do not have data of antiviral susceptibility in our country. So this is going to be a very risky practice to prescribe antiviral empirically to eligible or apparently eligible patients. Procedure change after testing. So if the patient is posted for some intervention, for some surgery, and this can, your diagnosis can have a life-saving impact on the patient, because certain surgeries, certain procedures are uh, do cause stress, and the immunity level may be lowered for some time. So if the patient is harboring some uh, viral infection, or I mean after the major surgery or major intervention, this may flare up, and there may be complications after the surgery. So that decision is feasible only when you go for a diagnosis properly. And for the patient outcome efficacy, patients are improved with test compared to or without, and morbidity and procedures avoided with testing. So this is again very much linked to patient outcome, and directly linked with patient satisfaction and quality adjusted life years impact. So a single diagnosis can actually impact a life. And for the societal efficacy, yes, cost benefit or cost effectiveness impact from societal perspective. So that's also very, very important. So overall, you are actually helping the society, not only in terms of money, but also in terms of saving lives, in terms of preventing antivirals, in terms of preventing antibiotics. So the overall impact is huge. So not only for influenza viruses, but also there's recommendation for testing for non-influenza viruses, again coming from IDSA. So similar guidance for other non-influenza viruses exist only in selected immunocompromised host guidelines, where initial testing for multiple viruses in addition to influenza is endorsed. So IDSA also endorses the role of molecular diagnosis even for non-influenza viruses for certain subset of patients. Now there are certain questions. So question one, to test or not to test? I'm sure my next speaker will say that, I mean, molecular diagnosis is gross, overused, which is a general thought at times. But whether to test or not to test, what the guideline says, the answer to this question depends on a variety of factors. Number one, patient's severity of illness, duration of symptoms, comorbidities, net state of immunosuppression, availability of other ancillary test results at the time of presentation, anticipated turnaround time of results, and disease prevalence. That means the pretest probability of a given disease in that locality. So keeping all these factors in mind, you have to take a call whether to start, whether the patient should be tested or not. So I'm not saying that every patient presenting with viral infections should be tested. No. So if you follow the guideline, there's a fixed criteria. So these patients should definitely be tested, because patient outcome is very closely linked with this testing. Otherwise, you can have very, very adverse situation later on. Second question, if I decide to test, which approach is best? Testing for influenza, the CDC and IDSA guidance both favor molecular detection of influenza as opposed to antigen testing in the outpatient and hospital setting. So this is very clear coming from IDSA. I have the references attached, so needless to say, enough evidence to comment that yes, this is supported by CDC and IDSA. You have to go for molecular testing. Testing for SARS-CoV-2, I don't think it's needed. Everybody knows in the world now that the role of molecular diagnostics for SARS-CoV-2. Testing for a broad range of respiratory pathogens simultaneously. Yes, upfront multiplex testing for multiple viruses may be most cost-effective in pediatric patients, where it can reduce unnecessary antibiotics as well as chest radiographs. So not only antibiotics, you are actually preventing the child from exposure. So again, this reference is coming from IDSA, and definitely something to ponder. Third question, does partnership with antibiotic stewardship enhance the impact of respiratory diagnostic testing? Antimicrobial stewardship guidelines advocate rapid testing for broad panels of respiratory viruses as an important intervention to reduce the use of inappropriate antibiotics. We all know that when you come to a diagnosis very quickly, you can stop antibiotic, or if viral etiology is not there, you can consider antibiotic. Based on the viral etiology, you can consider antiviral. So all these informations, all these decisions can be taken only when you test, and your antimicrobial stewardship at the community level, at the outpatient level, at the hospital critical care level is heavily dependent on this molecular diagnostic test results. And we have seen that the highest rates of antibiotic consumption, as high as 51% with prospective audit and feedback, were observed when a virus is detected, bacterial cultures are negative, and chest imaging is normal. So in these situations, you just stop the antibiotic and go ahead with supportive treatment. And if at all some antiviral or other innovative management is there, you can go ahead with that. We have seen there is literature to suggest that highest rate of antibiotic discontinuation has happened in this way. Now, this is again important. We have a publication to say the other distinct advantage of molecular techniques over conventional methods is the ability to quantify viral pathogens. Although qualitative molecular tests should only be used for diagnosis, viral load change in respiratory specimens can be used as an indication of test of cure for therapy monitoring. Very interesting concept, and I have the reference to support this data. Also, identification of antiviral resistant variants. So we know that rapid detection of pandemic variants, this is really important. And also, we have to distinguish between different strains from circulating epidemic strains. It has got huge epidemiological importance. This has got very much importance in restricting travel, especially for international travelers. So this is all known to everyone. So not only that, identification of antiviral resistance variants is equally important for pandemic surveillance and patient management. Recent studies have reported the use of novel molecular methods to screen for the presence of the H275Y resistance mutation in the neuraminidase gene. So based on that, you can actually scale up your surveillance. The clinician can take a call whether to go ahead with oseltamivir or maybe some other antiviral wherever this is available. In addition to accurate detection of the H275Y oseltamivir resistance allele, samples collected at multiple time points even showed a switch from wild-type oseltamivir sensitive 275H to oseltamivir resistant 275Y population after 9 days of treatment. So what does this statement say? It says that not only at the time of diagnosis, but again, if a patient does not show response, appropriate response to antivirals and other supportive management, you can actually check whether the oseltamivir is working or not, whether it's been replaced by oseltamivir resistant population. So even this is feasible with the help of molecular testing, and these are very interesting and innovative concept. Not all antivirals are available in our country, but this is a food for thought. So starting from the journey, from the point the patient comes to the hospital, goes to the emergency department, goes to the outpatient clinic, gets admitted into critical care, till his or her stay in critical care. So at every point, we see the role of molecular diagnostics, and this is actually life-saving. So these are my references. I rest my case here. Thank you so much for your kind attention.
Thank you, Dr. Gupta, for your excellent talk. I really appreciate several points, and I pointed out also several burning questions, but that to highlight some key points regarding your speech and the arguments you brought for the use of molecular testing for diagnosis. I think that the second speech will have to bring their own arguments regarding the non-use of molecular testing for clinical cases regarding viral infections. I have the pleasure to introduce Dr. Frial Khamis. She is a medical doctor. She completed her medical honors at the Sultan Qaboos University in Oman in 1993. She completed her residency program in internal medicine from the University of Minnesota in Minneapolis in US in 1999. She has also completed 2 fellowships programs for both in infectious diseases and medical microbiology at Duke University Medical Center in Durham in North Carolina. And she is a senior consultant and head of the infectious disease unit. She's also a deputy of Directorate of Internal Medicine at the Royal Hospital in Muscat in Oman, where she chairs both the Antimicrobial Stewardship Committee and the Infection Prevention and Control Committee. Dr. Frial, the floor is yours. And we are listening to you. Thank you.
Thank you very much for the kind introduction, Mr. Chair. I am sharing my slides, so I hope that you're able to see them. So I was asked to talk about molecular diagnostic should be used for patients present with moderate to severe viral infections. And I want to tell you, start by epidemiology of respiratory viral infection. We know that viruses are important and common causes of community-acquired pneumonias, the most severe form of a respiratory viral infection. We know that in the para-COVID era, we had something like more than 22 to 44% of etiology of community-acquired pneumonia was due to viruses. In addition to detecting the virus for diagnosis workup, you heard from the previous speaker as well. There is an important in diagnosing viruses to facilitate epidemiological surveillance. To use, we heard about the importance of use and timely antiviral therapy, control of nosocomial infections, and wise management of antibiotics and resources. But the question is molecular diagnostic the only way to detect viruses? Absolutely no. We have plenty of conventional diagnostic methods that we developed over the years, and some of them are very rapid, and we use them for the diagnosis of respiratory infections. We have the direct examination, the immunofluorescence that we depend on in our labs on day-to-day practices. So detecting influenza A, B, parainfluenza, all those things have been done in addition to the moleculars. We have also serologies, and they are the classical techniques as well as advanced techniques. And we have been using serological diagnosis very often and quite rapidly. So what I'm saying that clinicians need to be aware of the significant drawbacks and the limitations that are applied to the molecular diagnostic. It's not, as my colleagues have said, it's not the cornerstone of the diagnostics that we currently have available. And let me give you some of the caveats where molecular diagnostic have failed us or we had major problems with them. Detection does not necessarily mean infection, and we do see this quite often in our clinical practice. Many respiratory viruses are detected in patients who are healthy and they don't have symptoms. What to do with that detection? There are also sometimes the mere presence of a virus in symptomatic patients does not necessarily mean that there is an infection and I need to jump and start antiviral in that patient. The second issue and caveat with molecular diagnostic is viral loads does not correlate with the risk of deterioration. So sometimes we have a very low viral load and very poor clinical outcome. Conversely, patients with high viral loads may never develop a severe illness. So this is an important concept, and I want you to keep in your mind, because at the end of the day, the virus, when it enters in the body and start the damage, particularly in the respiratory symptoms, you want to be able to detect these consequences on the patient rather than mere presence of the virus itself. A third problem, a major problem as well, non-viable virus and dead viruses and fragments, they are also detected and is positive with using molecular diagnostics. And detection never means actual virus replication. So it's kind of underestimating. If I found a virus and I say that this virus is probably live and this is the main cause of what is going on in this patient and the rapid deterioration in this patient. And we have seen an example on that. And I want to highlight SARS-CoV virus as an example to what my colleague said. The overuse of molecular diagnostic was very predominant in the era of COVID-19 pandemic. And this was a phenomena that happened both globally at low resources countries as well as high resources countries. But let's see what was available. We had two types of testing. We had the molecular testing, and we had later developed the serological or the antigen testing to detect the specific antigens and antibodies. We had NAT, the gold standard, as my colleague said, the real-time quantitative reverse transcriptase, PCR testing. And you can see we were bombarded with different types of equipments, machines, technologies, and everybody were running to kind of push us to select one of their technologies on behalf of the others. But then, I mean, we all run and jumped into the molecular, absolutely. Then we found out that really the performance of a molecular diagnostic is dependent on multiple factors. And these are the factors that I have listed in this slide. If you go into the detail, the first factor, viral load, it was a real problem because in COVID, the biodistribution of the viral particles vary from one specimen and another. And it also varies how deeply you have collected your specimen. In this particular study that I'm sharing, more than 1,000 specimens were tested for biodistribution of the virus. Highest positive rates were from deeper tissue, from lavage. However, we know that the nasal swabs were the best in detection because there was high viral load in the nasal swab. So what I'm trying to say, plenty of false negatives if you don't correct the correct specimen and the correct type of a specimen and how deep you are taking the specimen. It could be negative, falsely negative, and you will assume that your patient does not have COVID. And that's why we shifted from just purely depending on diagnostics, molecular diagnostic, to more understanding the detailed knowledge of the symptoms, the epidemiological history, and imaging as well. We depended on imaging for quite a lot of time during that pandemic. The second problem with the performance of molecular diagnostic that my colleagues did not address, inappropriate sample collection time, when to collect the sample. Because we know, again, that there is a variation on in regard to the test, performance of the test depends on whether you are collecting in early stages of infection, or you are collecting after the symptoms appear, or you are collecting at the end of your disappearance of the symptoms as well. And we know that highest pharyngeal shedding was seen in the first few days of symptoms, peaked around day 4 in the throat, and then again in the sputum. So which sample should I take? Should I take the pharyngeal? Should I take the throat? Should I collect the sputum samples? It was really confusing process to send sample during that time. In addition to that, my colleagues said sensitivities, and when we talk about sensitivity, we talk about sensitivity of the test, but we also talk about the importance of there are many factors affecting the sensitivity of the test that is outside the actual, the test itself. It's all the other processes that are happening. And to increase the sensitivities, there are factors that will affect the sensitivities, definitely. There are the technical deficiencies in the product design, unstable reagent, inappropriate amounts, irrational design and impurities of the oligonucleotide, and certain primers and probes also, they are inherently have issues with sensitivities. And yes, he said that you are able to detect, the mutations sometimes, but in COVID, the virus was mutating so much, and we were lucky that some of these molecular diagnostics were able to detect this mutation. But in real life and with other viruses, with all this mutation, you might not be able to detect with your current molecular diagnostic, and it's a chasing process. And I'm glad that Dr. Matwabta mentioned, he mentioned that we were able to control the pandemic with the appearance of the molecular diagnostic. Actually, no. 80% of COVID positive cases were initially transmitted when the patient was undetected in the period before sending the molecular. And many of these tests, many of these transmissions were missed. And that's why we were not able to control the pandemic. And we had millions and millions of cases. And this is because the diagnostic tests that came on, the molecular diagnostic came very rapid. They were not validated initially, and no one validated them later as well. The diagnostic timing that I have told you, the issues with it, the low sensitivity, despite the, and I showed you how it depended on where the specimen were taken and when they were collected as well in times relation to the illness. And then we had also low viral load in some patients. And that's why we moved away sometimes from this diagnostic. So we have on the one hand molecular testing, on the other hand, we had serological testing, and we moved to antigen testing from the molecular testing, because yes, sensitivity is high in molecular testing, but the specificity is much higher when we use serological testing and antigen testing. And also the other caveat, as I mentioned, in the process as well, many false negative results. We have seen this because there is a process from the time you deliver your sample till you get the result. There could be inappropriate sample collection, storage, transfer, and purification that affects the process. Quality of the RNA extracted from the swab will affect presence of inhibitors. Genomic DNAs of the host could interfere and compete with the probe and primer annealing. Use of chemical enzymatic reagents can degrade the DNA of the virus and the RNA of the virus. Mutations as well in the genome can compromise the detection. And then we have the false positives. And remember, plenty of false positives because of contamination from the environment, the lab, the instrument, and also the detection of viable and non-viable viral particles. So personal requirements are very, very important. Quality assurance is very important when you are implementing these molecular testing. And also you will need a space, laboratory requirement, which is not available in many places and countries. And there are even more important things than to kind of work in the labs that they need to prioritize than setting up benches for laboratory testing for moleculars. Cost is a significant drawback. And no, it's not just the reagent. A single PCR test kit may cost over $100 US. Setting up the diagnostic and processing lab, $15,000 US. And no, analysis time takes a long time. It's not that rapid. And also sample to result turnout time usually is more than 24 hours in comparison to some of the immunoassays and some of the rapid antigens that are available and you can implement in point of care as well. So what's the solution and what's the way forward? Is it the NAT testing, molecular testing? Actually, it's not only the NAT testing or the diagnostic. We need to integrate those with the biomarkers because you want to know what's the impact and effect in that individual host. And that would not happen without the availability of biomarkers. So the way forwards are the integration of these diagnostic testing with biomarkers. You have respiratory virus infection, local tissue injury, a chain of downstream immunological events happen, the disease progress, and you have severe lung injury. You want to detect the severe lung injury in order to manage your patient and not just the presence of the virus. So by integrating and using diagnostics and biomarkers, you will be able to risk stratify. And that's the most important thing, because currently we are not able to do that. We'll be able to send a particular patient to ICU or to send that patient to home. You will be able to not only detect the virus, but you'll be able to stratify that patient. And then you will be able to select the immune therapy in addition to the other therapies, because we know that we don't have a lot of viral treatments. The only thing we have is oseltamivir for influenza, and for COVID, we have some of the newer, but with the efficacy that is not as well to the mark, especially with the presence of vaccination. So novel immunotherapy can be selected based on this. So the way forward really is to integrate and to work on these new technologies that are integrating the biomarkers within your day-to-day practices. And with this, and with the conclusion that viral diagnostics are important for infections, for management, for diagnosis, for infection control measures, to shorten the treatment of antibiotics or antiviral and decrease the indiscriminative and selective use of antiviral. But correctly identifying the viral etiology of respiratory tract infection does not just require molecular diagnostics. There are still other diagnostic methods that we can utilize, less expensive. They also are very important for clinicians to recognize the limitation of molecular diagnostic technologies. It's very important and essential that there are gaps in the speed, ease of use, coverage, usefulness of true positive and true negative. And remember COVID, we had so much, we spent millions of money and keeping patient in isolation while they based on PCR testing, while they could went back to their work, or they could went back to their usual lives. Also, false positives and false negatives are important drawbacks and limitation to moleculars. Cost is a big one, and future really is in the combination of more than one way or strategy for diagnosis. So yes, PCR is an easy thing to do badly, and the likelihood of what would happening and contamination and data misinterpretation from poorly executed molecular testing are the nightmares of even the most forward person who's supporting molecular diagnostic and the molecular diagnostic advocates. I will stop here. Thank you very much.
Thank you very much, Dr. Faria, for this excellent talk. I think that both of speakers have brought some key points regarding the use of the non-use of molecular testing. And I was in my thirst listening to both of you, and many questions are to come. I think, Dr. Kim, now it's time to have the results of the polls.
In fact, we're going to run the second poll now, yes. And that is to get people's opinion, whether their opinion has changed as a result of the two presentations. Can we have the next poll, please? So we're again asking about the role of molecular diagnostics in current clinical practice. Should they be used for patients who present with a moderate to severe viral infection, for or against? And then we're going to show the results of that after Well, in fact, if they're available now, I wonder if we can see the results of the two questions. Is that possible, or do we need to? I'm just getting a. No, okay. So we continue with the Q&A, and they will present the results after the Q&A.
Okay.
Thank you.
Okay, if we have any question from participants. Okay, I think that I will begin. I have some burning questions regarding what have been brought by both speakers. Both of them, they brought several arguments regarding the use of testing. Dr. Gupta, he brought the argument of the cost effectiveness and what it brings to the health system and also to the community, the reducing the turnaround time before diagnosis, and also using the use of antibiotics in some cases. And also he talked about the sensitivity and specificity of user test, and also the predictive values, which is an important thing regarding that. Dr. Furia, from the other side, she presented some caveats in molecular detection assay, and she focused on COVID-19 and the experience in COVID-19, which was a great experience for all countries. And the example was a very interesting example regarding also some aspects that she brought regarding the pre-analytic, the quality assurance, which are one of the main components that may affect the use of molecular testing. My question is for Dr. Gupta regarding the viral load. He said that molecular testing can help to for the quantification of viral load. If we are talking about COVID, if we stick on this example, because both of you have mentioned that the quantification of viral load depends on several factors. Some factors are related to the way the matrix we are using, if nasopharyngeal, oropharyngeal, or alveolar.
Bronchoalveolar.
Yes, bronchoalveolar. It's depending on both of that, and also it depending on the way we are doing the testing, and also the time of the infection. In the beginning of infection, we have upper infection, and after that we have infection in lungs. And quantification of virus in that perspective, for COVID and for flu, in my opinion, is not useful for clinical practice. What your opinion about that?
Yeah, this is a great question. See, this is a concept. So it's not, very well spread. And obviously, I do agree. Primarily, you have to look into the claim of the test. So if it is a qualitative test, let's not deep dive and, use it quantitatively. We have seen that a lot of patients, misuse based on CT values and all. So primarily, you have to look into this, whether this test is quantitative. And again, I'll say this is a concept that if at all we can use this reduction in viral load as a point as a proof of care, test for cure. And also there is a certain dilemma, as the other speaker, Dr. Fadil, has said, that there's a confusion whether detection means infection. So perhaps this will also point towards that thing, because what we are talking today is that role of molecular diagnosis. I'm not saying that it replaces clinical acumen, clinical calls. So there are certain things which can actually aid in these diagnostic situations, and which may be useful, because as these tests are very sensitive, which can be problem at times. But considering the pandemic situation, especially if we look into this COVID-19 pandemic, we have to have some tests which is very sensitive. But at the same time, there will be some chances of false positivity. So it comes, needless to say, with that. But during a pandemic situation, we must have something highly sensitive. So during those times, we should have, rather, we can have some other ancillary findings or armamentarium, which can aid to differentiate whether really we are dealing with infection or present infection or past infection, or suppose a patient is recovering. But again, at the same time, there are certain tests which are highly sensitive. This can also pick up infection when the patient is in incubation period just within 4 days of exposure. So you just cannot deny that aspect as well. Thank you.
Okay, thank you for your answer, but I have another one. If we have no coming question regarding the audience, Dr. Kim.
Sorry, no, I have no other further questions coming in.
Okay.
Just looking at the chat box. We have invited Dr. Rajadar to join the session, and we have no further questions from the audience. I wonder if we could perhaps talk about the implication of some of the new technologies that are coming through and what impact they might have. I mean, we're seeing there seems to be a revolution happening in technology at the moment, and I wonder what implications this has for the diagnostics. Any comments about that?
Yeah, I might just have a small comment here. I mean, the key thing is that we should recognize that the presence of virus does not equal infection. And we quite frequently use these terms together. It's important to recognize that the most important thing is not the presence of the virus, is be able to see the consequences of the virus. And one of the challenges in COVID was we did not know which patient will progress and which patient would remain as it is, despite some people would have very high CT values, and they will progress. And on the other hand, there would be patients with very low CT values, and they will do quite fine. So there is just the presence of the virus did not help us. So that's one point, important consideration that we need to think of. The second thing is similarly to that. I mean, the role of diagnostics in general is very, very important, and we don't want to dismiss that part. And we don't want also to dismiss the role of molecular diagnostic as well. At the end of the day, all these are tools that we are using, and all these tools helps us like in a step to get closer to the diagnosis. So knowing when to use them and how to use them is very, very important. And I think this, both of us, myself and Dr. Gupta, agreed on the fact that the use of molecular diagnostic should be judiciously, and you should know when to send the correct specimen, how to collect it, and how to process it. And also the turnout time is very, very important.
Yeah.
I think the newer diagnostic biomarkers are really the way forward. And I think we need to invest more time, research, in the biomarkers, because clinically, at the end of the day, you want to recognize the patient who will do worse, and those would be the patient that you will elect to start antiviral in. And if you have patient who will not do bad, why even throw an antiviral on them, even if you know that there is a virus that has been detected there? So the true stewardship and the true using resources in the correct way will be by integrating the biomarkers in our day-to-day clinical practice.
If I may add a couple of points from my side. Just a question to Dr. Farial. Very well said, but will you be comfortable to treat a consequence, infection consequence in a patient without coming to the diagnosis? So perhaps, you know, diagnosis starts everything, and then even based on the diagnosis, different immunological consequences become different, and your clinical experience, your management, even as a matter of fact, biomarker guided treatment, which beautifully you have explained, this is really the way forward. So everything becomes perhaps very, very relevant only when you come to a diagnosis first. So this is my way of thinking. But I do appreciate that you actually spoke on the future aspect, definitely biomarker guided therapy. But my humble submission is maybe everything, just the journey starts with a diagnosis first. And also, as you spoke on rapid antigen test, you see, this is, yes, I agree that these days it is replacing RT-PCR. But if you look into the sensitivity, I mean, again, it's having very high specificity. That means if it is positive, definitely it's true positive. But if it is negative and the patient is still having symptoms, then your next level of action becomes again RT-PCR. And if you look into certain package inserts of certain rapid antigen tests, so this is valid only during the initial first 7 days and only when the patient is symptomatic. So what are we supposed to do when we're screening apparently asymptomatic patients? So in those situations, actually, even the rapid antigen tests are off-label, become off-label. So as simple as that. And I do agree, a lot of pre-analytical issues are involved. But again, this is part and parcel of every test, and no single test is complete. So completely agree with your point. And there lies the importance of clinical acumen that as a doctor, you bring into the practice collectively as a whole. Yeah, thank you so much.
Thank you, Dr. Gupta. No single test is the way to go. And knowing how, when, and the limitation of each test is very, very important.
Yeah. And also a few points you very well, pointed out, that cross-contamination, ease of use space, but I can definitely point out to certain, newer generation tests where you have closed systems like GeneXpert, where this is grossly, mitigated. So like for batch testing, conventional PCS, yes, there are problems of cross-contamination, false positivities. But if you look into the future of molecular diagnostics, most of the test platforms are closed. And these problems, these are, real perpetual problems with open system, which are very grossly mitigated. But very important point. Thank you.
Yes, thank you, Dr. Gupta. Thank you for also mentioning the use of such technology like point of care, like from CFID, but there are other technologies, similar technology that framework, but using this technology is not affordable for many low-income countries. So a lot of effort have to be done by manufacturer. I want to go back to one point regarding the use of antigen testing and molecular testing. The use of those two technologies during the pandemic is different in an epidemiological context, different than the pandemic. During the pandemic, we were using PCR to detect acute cases. That using a rapid test, antigenic rapid test, was not useful. And at the beginning of the pandemic, we have not enough information regarding the intrinsic performance of those tests in terms of sensitivity, specificity. And even after that, we have several antigenic tests were developed, and it was not able to use this test for acute cases, because in the first days of the infection, from the first to the fifth day of the infection, rapid tests using rapid test, antigenic rapid tests are negative. So we were obliged to focus on using molecular testing, despite the fact that even using molecular testing, we have a gap that is not filled related to the technique, the sampling, and also the sensitivity of the test. More than 30% of PCR may be missed because of the testing requirements. So using antigenic tests during the pandemic, once we had good tests with good performance, was helped to manage the pandemic. But now since we know the pandemic, we cannot base our strategy on those tests. So we have to be careful on that. And then thank you very much, both of you, because you were cautious using your arguments. And both of you are complementary. So we can, in my 2 point of view, because in the daily practice, we use both arguments. Clinical and laboratory issues are gathered to do a good diagnosis for patients. And the last point that Dr. Ferrier raised, and I totally agree with that, is the use of biomarkers. And now it's the medicine of the future, and is also a kind of personalized medicine in terms of diagnosis. And it has to be noted that also these biomarkers are also molecular testing. And thanks to the COVID-19 and the tremendous evolution of technology during these two past years, now some biomarkers have been raised and tested. And in the next future, we will be able to use these biomarkers for clinical diagnosis and in a personalized manner. Thank you for your input and for this excellent session. Thank you for the effort, for your excellent talks. And I give the floor to Dr. Kim.
Thank you, Dr. Hisham, for moderating it so well.
Yes, I agree. That was very, very well done. Thank you. And to Dr. Farial and to Dr. Debkishore. Really good presentations, and you know, it's a very hard thing to argue against the diagnostics, but you know, you did it so well, Farial. Fantastic job. So we're moving on to our next debate, and sorry, here we go. This is are the results of the two polls, and as we can see that initially it was 50-50, evenly split between whether we should or should not have be using molecular diagnostics, but clearly there was a shift to 2/3 of the audience believing that that molecular diagnostics should be used for patients who present with moderate to severe viral infection. So that's interesting. Your presentations obviously had an impact. So thank you for that. So we're now moving on to the next debate, and this is going to be moderated by Dr. Lance Jennings. We will also be having a poll as well about this one in the same way that we did in that first debate. So we're going to put a poll up now which asks whether we should be stockpiling COVID antivirals now. So please respond to the question, and we're going to ask the question again after the two presentations, and then we will show the results right at the end. So I would like to now introduce Dr. Lance Jennings. I've known Lance for many, many years. Lance is a semi-retired scientific advisor. Well, sorry, he is retaining roles as a scientific advisor. He's a virologist, and he's involved with the Canterbury District Health Board in New Zealand. So as you can see from the information on the screen now, he is a co-founder and director of the Asia Pacific Alliance for the Control of Influenza, and a past president or chairman of that organisation. He's, as I mentioned, semi-retired, and Lance has been instrumental in the development of influenza control strategies for New Zealand, including the introduction of government-funded influenza vaccine, the establishment of influenza awareness education, and pandemic preparedness planning. The other activities he's involved in relate to advisory roles to the New Zealand Ministry of Health on HPV and immunisation, and have involved advisory roles to the WHO for measles and influenza in Europe, Asia, and the Asia-Pacific region. So without further ado, Dr. Lance Jennings, over to you. You're on silence, I think. You're on mute, Lance.
A great start. Welcome, everyone. And thank you very much, Kim, for that very generous introduction of you. Yes, I am retired, but it's really fascinating being part of this meeting and hearing the presentations yesterday and today, and congratulations to all the speakers and the organisation of this meeting. The next debate, which you've already voted on, is stockpiling of antiviral medications for COVID. And you will have all been involved in pandemic preparedness planning over many years, and had plans in place for your own countries, of which initially developed for influenza, and it was straightforward. Stockpiling of antivirals was limited to really 2 antivirals for stockpiling purposes. With COVID-19, the situation is quite different. We have been adjusting our pandemic plans. We've effectively been flying an aeroplane while we're still constructing it. And so this debate today on stockpiling of antivirals for COVID-19 has potential for some interesting discussion. We have 2 speakers, Professor David Smith and Dr. Rana Ashgar. David will be talking on the for stockpiling, and Dr. Ashgar against stockpiling. So Dr. David Smith, in front of you is an outline of his professional expertise and his interests. And he is currently medical microbiologist at Pathwest Laboratory in Western Australia and clinical professor in the School of Medicine at the University of Western Australia. He is the director of the National Influenza Centre in Perth, and clinical lead for microbial surveillance unit at Pathwest as well. He serves on many Australian, national and international committees and advisory groups, including those advising on pandemic influenza, Zika virus, Ebola responses, and others not listed here. He was a past chair of the Public Health Laboratory Network in Australia, and recently retired as the chair of the National Arbovirus and Malaria Advisory Committees in Australia. He has an interest in emerging infectious diseases, respiratory viruses, mosquito-borne viruses, and has authored and co-authored over 200 scientific publications. David, we look forward to your arguments for stockpiling antivirals.
I'd like to thank the organisers of the meetings and of this session for giving this opportunity to speak on this very important subject. I'll be presenting the positive view of stockpiling of therapeutic agents for the prevention and treatment of SARS-CoV-2 infection. So the first question is, why do people stockpile? And stockpiles have become pretty common around the world for a variety of reasons. And really, it's to try and strengthen your capacity to respond to new health threats. and to avoid impairing that ability to respond because of inadequate stocks of essential reagents or of equipment or of therapeutic agents. And you do that by ensuring that you have rapid access to the equipment, the therapeutics that you need in the amounts that you need. And to do that, you also need to define the specifications for the products that you want to use. So what do you actually want? It allows you to plan then for how you might store and disperse your stocks in preparation for a pandemic, hopefully, or for changes in a pandemic. And allow you to planning for both the initial and ongoing changes to how you might choose to use those stockpile items. Also, because it's not being done in such an urgent situation, you have a chance to negotiate for price and supply pipelines rather than having to go to them in a rush at the last moment and not be able to negotiate such a favourable deal. What's commonly in a medical stockpile, and we're not yet talking about specifically about therapeutic agents, but in a medical stockpile, of which there are many examples, they generally include personal protective equipment, things like gowns, masks, gloves, etc. Other forms of medical equipment that's required. It might be the basic equipment for caring for patients. It might be specialized things like ventilators or temporary beds in order to meet increased demand. Laboratory testing equipment also in order to prepare for a response. And if there are preformed test kits like point of care test kits, those as well. The subject we'll be talking about a bit more, therapeutic agents. You want the things that are actually designed and directed at your emerging threat, and in this case, of course, we're talking about SARS-CoV-2, but also therapeutic agents for expected complications. And in this situation, it would be things like antibiotics for pneumonia secondary to the COVID-19. And also then reagents, such as laboratory reagents for testing, things for cleaning, sterilization procedures. And I've shown you here this Australian government page for our national medical stockpile, which is just such a strategic reserve of a variety of components important in being prepared for a good protective response to an emerging threat. Now, with SARS-CoV-2, in terms of therapeutic agents, we have to consider the disease itself and what we're trying to stop. And really, SARS-CoV-2 clinical illness fits into two phases. There's the early phase, which is associated with early infection, milder disease, and is dominated by the replication of the virus. Then as we go to the later stages of the disease, particularly the pulmonary phase, and then disseminated involvement of other organisms, you actually have an important component of the host inflammatory response. So when we're looking at things that we might want to have within a stockpile, we need to have things that will address both of these phases as they become available. So in that early viral dominated phase, we're looking at the antiviral monoclonal antibodies and antiviral drugs. In that later stage, we may still be using those, of course, the antiviral monoclonal antibodies, steroids, antiviral agents to suppress any ongoing viral replication, and anti-cytokine agents as well. And of course, what we stockpile for these various bits depend on what's available to us at that time. So if we look at how the sort of therapeutic agents we might want to put into that stockpile, there are the various direct antiviral targets, the binding site of the spike protein to the receptor, the virus fusion which is assisted by host cell proteases, particularly this temperate S2, the stage of cleavage of the polyprotein by the viral proteases, the stage of RNA replication by the RNA polymerase, and then the virus release phase right at the end here, in which you might potentially interfere. In terms of host responses, these are particularly directed at cytokine induction and dealing with the excess level of cytokines in the severe disease. So the drugs that we actually do have currently provisionally registered in Australia fit into three groups that you might consider for stockpiling. There are the ones that are the antivirals, and all of these currently with registration are directed at the protease. There are three of those currently available. There are also a range of neutralizing monoclonal antibodies directed at the spike protein. And then there is one current therapy directed at the host cell responses, an anti-IL-6 monoclonal antibody. These are recommended either for the treatment of severe or critical disease, like the remdesivir and the tocilizumab, and many of the others are directed at mild or moderate ambulatory disease in ambulatory patients in order to stop progression to more severe disease. And this would be things like molnupiravir, Paxlovid, and the preform monoclonals in Evusheld. Those that aren't currently in many of the stockpiles that are available are of the antiviral drugs, Paxlovid and molnupiravir, and the remdesivir used for more severe disease. Of the antiviral monoclonal antibodies, sotrovimab is the one that's currently stockpiled because that's the one that retains the highest activity against current strains of SARS-CoV-2, and tocilizumab as an anti-cytokine therapy. Now, if we look back on just briefly on what I said previously, these also have, of course, some variation in their storage conditions and also variation in their shelf life. And that's important in terms of ensuring you get maximum utilization of your stored therapeutics. And many places have voted with their feet in this, in that medical stockpiles have been widely developed throughout the world and are established in a number of countries. Of course, Australia has its national medical stockpile to deal with both equipment and therapeutic agents for treatment of COVID-19. The US, of course, has one, and a range of many other countries have their stockpiles. And I noticed also that India is stockpiling critical drugs in preparation for future waves of COVID. If you're going to have these stockpiles, you have to then set up some structure in which you're going to control the access and the use of them in the way that you had intended for the purposes of preparation. This is the Western Australian government's website, which has access criteria for medicines to treat COVID-19 that are part of the National Medical Stockpile. And this is a somewhat lengthy document with a lot of information contained over several pages in terms of how we might use these in different groups. And you can see the risk groups and the prioritization of use sits across three groups: Tier 1, Tier 2, and Tier 3. And the more that's available, the further you can go down these tiers. So Tier 1 would be the highest risk groups, usually with multiple comorbidities or severe immunosuppression, and then going through to milder disease. That then also specifies the process for accessing these drugs in order to make them available. A stockpile is no use unless people can get to it and use it in a timely manner, of course. So there are a few steps in how you might then distribute and use that stockpile. First of all is getting the message to the people. So you need to ensure that patients seek out medical attention at a time required to make effective use of the antiviral. So for things like molnupiravir or Paxlovid, where you need to deliver it shortly after the person tests positive, you need to make sure that they know to go and get tested early and to see a medical practitioner to access the drugs. And the medical practitioners need to know about how they can access the drugs and under what circumstances. And certainly within Australia, we experienced problems around that when we released antiviral drugs and how we might be able to get them in a rapid manner to those who needed them. And indeed, there are therefore online a number of alert messages for the public and patients about what's available, and also instructions for medical practitioners on how to access them. And since a number of these drugs are now distributed through community pharmacies, also through the pharmacy system in how they access and stock them and distribute them. So the message then is, if you're going to do it, then do it properly. And this is a somewhat busy slide, but I do want to go through the things here because there are several things you need to address in making your stockpile and operating a stockpile. You have to first, of course, establish access to supplies, and that requires early engagement with industry for both those initial and the ongoing supplies. You then need to engage in regular reassessment. Have you got enough for the planned usage or for the change in usage? Are there better agents that come along? Are there some which are no longer valuable in the management of the condition? Then you have to have a prioritization list for use. There is rarely, it's certainly in the initial phase, enough of it to be used for everybody you might want to use it for. So there will be some hierarchy of use required. It also, of course, you don't want to overutilize what are very expensive drugs either. So you do need to ensure that you're going to get a return on your investment in this stockpile. Storage, of course, you need to have the right space and conditions in which to store it. And that might be in a single large central stockpile, or it might be in smaller stockpiles, either in specialized facilities or in hospitals or possibly in pharmacies. With the correct storage conditions, temperature and humidity, and a knowledge of what the shelf life is that can be maintained under those conditions. Then those issues of accessibility that I mentioned, and how you police your priority rules, and how you have an approval process which is sufficient to control access, but not over the top such that it becomes too clumsy a process. I've talked already about physical locations you might use and the need for user-friendly process for provision of the drugs. And then, of course, what you should write into this is these periodic reviews. And in Australia, we've had one review already by Australian National Audit Office. And that did indicate that though generally the process of stockpiling at that stage had been done well and was appropriately, there were some issues around timeliness of establishing the stockpiles, methods for distribution, and a few other issues like that which needed improvement. So that's a continuous process. And then I guess finally, there you go, start your stockpiling. And I'll leave you with those thoughts, and thank you for this opportunity.
Thank you very much, Professor Smith, for that presentation. At this stage, we will move on to the second presentation, and I will invite Dr. Rana Ashgar to talk to us about reasons for not stockpiling antivirals against COVID-19. Now, Dr. Rana Ashgar is Chief Executive Officer of the Global Health Strategists and Implementers. He is a member of the WHO International Health Regulations Development Group, expert in epidemiology and surveillance, an adjunct professor of epidemiology at the University of Nebraska. He was advisor of the Federal Ministry of Health, the Core Committee on COVID-19, and is a member of the advisory committee to WHO in Pakistan on infectious diseases. And he has served as program manager for child survival program in Mozambique. And he is currently a faculty member at the London School of Hygiene and Tropical Medicine and Research Associate at Stanford University. So welcome, Dr. Ashgar. We look forward to you introducing the debate against stockpiling of antivirals for COVID-19.
To all my audience who is all over the world and in India. Today's our topic is stockpiling of antiviral medications, and argument is that we should be stockpiling COVID-19 antivirals now to protect us for the future waves. I will be speaking against it. Let's first talk or discuss what is stockpile, because sometimes people get a little bit confused about stockpiling and just stocks on the hand. So stockpile is a large accumulated stock of goods or materials, especially one held in reserve for use at time of shortage or other emergencies. So these are the stocks which will not be used until there is an emergency. While stock mean the goods or merchandise which are kept on the premises of a shop or a store or for routine distribution. So that's a bit difference from a stockpile. And stockpile is not used until there is emergency. Stock is regularly used and replenished as your needs. And just to give you a bigger example, that the food in our pantry is actually stock in our kitchen pantry. So there will be stock for some items for a few weeks. And for example, in Pakistan, India, most people will buy rice in quantity which will last them couple of months. Similarly, flour is bought like for a month use or that time of period. But if we look at stockpiles, stockpiled is the food will be bought, especially in those tin forms that it can stay as long as it survive as long as it possible, but they are not used. So stockpiles are kept for emergency purposes. So what are the possible benefits? Because if I have to make an argument against stockpiling of antivirals for COVID-19, first, broadly I should be aware of the counter arguments that why we should be stockpiling. And that's the number one argument in its favor is that it provide treatments until vaccines are available for a new disease or for the current disease, for the ongoing disease. It may reduce mortality and morbidity, and thus in result there will be less strain on the health system, and there will be, because you are controlling mortality and morbidity, there will be less panic in the population. But there are major problems of stockpiling, and what are these? Number one, it's extremely expensive to procure antivirals. You know that even a small country may need billions of dollars just to procure, you know, a certain amount of antivirals, and that's very true for COVID-19. The countries have different countries, even smaller countries have spent billions of dollars on that procurement. The second problem with it is that it has a short shelf life in most of the antivirals, which is a huge waste of resources, because this is, again, remember, this is a stockpile you are not using. This is not your monthly or 3 monthly supplies of your hospitals. These are the stocks which are kept for emergency purposes. And in my public health life, I have seen even in influenza antivirals that huge wastage countries have to suffer, because they bought the stockpiles of antivirals for avian influenza. That was a few years back. The country was keeping certain stockpiles, and because there was no pandemic, so that gone to waste. So again, country to country, for countries like us, that's a huge strain on our resources. And the third and our major reason of which is against stockpiling is that it's seriously determinant to equity. And I will give you an example. Normally, we have seen in COVID-19, both in vaccines and medicines, that as soon as they became available, the rich countries placed orders on them. And they bought unnecessary amounts of those vaccines and medicines, which they were not able to use until they got expired. And we have seen this problem in many Western countries, that you know, they bought so much vaccines which pretty much went to waste, or then at the last minute they donated to some poor countries in the last period of their close to expiry. That's wrong, because when the rich countries pay the price and take away all the medicines or antivirals from the market for the stockpiling purposes, that means the poor countries do not have access to those medicines which could be life-saving to their population when the next COVID-19 waves hits with a new variant which may be more dangerous or more lethal. So I think the concept of stockpiling actually goes very much against the equity we talk about, and especially for the poor countries. And we have not seen, not only in this vaccines and antivirals for COVID-19, we saw this for the even simple masks, because the rich countries again were paying huge amount of money for the N95 masks and other those kind of things, and poor countries couldn't find them in the market. So I think that's a major reason why I'm not favoring COVID as filing of COVID-19. But the biggest problem is the antivirus. Even if you stockpile, they may be benefit to you for certain extent, but resistance could easily develop in them. This is a known phenomena, and someone has said that even though the coronavirus has not developed resistance to, the most effective antiviral, which is Paxlovid, but how long that can last? And that's what someone wrote, that resistance is the hobgoblin of the antiviral medicines. Even with antivirals as effective as Paxlovid, after doctors deployed nearly every new virus-killing infusion or pill in the history, strains popped up either immediately or eventually with the machinery wrapped in just the right way to evade the threat. So basically, the history tells us that it doesn't matter, every antibiotic or antivirals eventually is going to see resistance by the microorganisms. So the question raises is that you have bought billions of dollars of antivirals for your stockpiling, taking the opportunity for poor countries to buy those as a stock, a running stock for their own health system, and thus you are threatening the lives of the population in the developing countries. But for what reason? Because maybe the next wave when comes of COVID-19, it will be resistant to existing antivirals, and that's not going to something new phenomena. That's actually a routine phenomena. So biggest problem which I feel is with stockpiling is that it's a clinical solution to a public health problem. So until now, I was giving you the materialistic or reasons that why stockpiling is bad, but now I think is the philosophical argument against stockpiling. Pandemics are not clinical problems, clinical issues, but they are public health problems. So its solutions should come from the public health side. That should be the priority when you're coming up with the solutions, that how you're going to control a pandemic or epidemic. And the clinical solutions will help you to evolve that strategy, overall strategy of controlling our pandemic. But you cannot control a pandemic, which we have seen in COVID-19, by just focusing on clinical solutions. And as we have discussed this, that how confident we could be that the next pandemic could be treated by stockpiles, antivirals, because there could be a new variant, a resistant variant, and so all the stocks you have bought will be waste. So what we should do? So according to the public health perspective, or my personal opinion, is best use of resources is by strengthening your public health system. If you have to spend $3 billion to stockpile an antiviral for the next wave, I think it's better to use most of its resources to strengthen your public health system, improving your disease surveillance system, so you could pick the next wave much quicker, so that you can deploy field epidemiologist team to respond to outbreaks, keeping them localized so they don't become epidemics and pandemics. You need to strengthen public health laboratory systems to identify those new variants much quicker than has been in the COVID-19. So we need to strengthen our alert system and response system for the new wave of COVID-19, or even a new pandemic of other disease. And these will be the best use of resources for your money. I wrote like a year back in my regular op-ed series, and I said, these were my words, which I said, rich countries cannot build a wall of vaccinations. And for here, I will add, they cannot build a wall of antivirals around their borders, as if transmission is happening somewhere else. Eventually, a new variant will breach these walls and make those populations vulnerable again. So it doesn't matter how much stockpiled medicine you have, how much stockpiled vaccines you have. If you are not working in a global public health perspective, eventually a new variant is gonna knock on your doors and threaten your population, and it will be it could be more resistant to existing antivirals. It could be more lethal, a new variant. So all your preparation will be, or investment have much lesser value. So if you want to work and make sure that your population in India or Pakistan or US or UK is protected from the public health dangers of pandemic, COVID-19 next waves, we all need to work together. You need to leave this idea of fighting a virus in our own territory. We need all to work together to control this. So next pandemic or the next wave of COVID-19, we need to strengthen epidemiology. And that was the most neglected field before the epidemic hits us. And we need to strengthen epidemiology to do what? We need to make sure that we clearly know how the virus is being transmitted. And for COVID-19, international bodies struggled for more than 1.5 years before admitting that it is the airborne. That's how that is the major route of transmission, that how the virus is being transmitted. And I think that reason alone has costed us in the millions of lives and sickness, because we were unable to clarify early enough. Even though the data was there, the information was there, but we were not able to adopt that understanding that this could be airborne, and that cost us human lives. And what are the risk factors? What are the vulnerable group? Because that's how you basically, what we call is able to protect your population without having huge stockpiles of antivirals, by answering those questions. So antiviral and vaccines, we need to invest on this. So don't consider that I'm against, the antivirals or vaccines. We need to have ongoing research on antivirals, and already it is being done. Many of you are virologists, so you know this much better than myself, that the next wave of new vaccines which people are developing are more generic in their how they act. Similarly, the antivirus on which the work is being done have a more wider spectrum of action as compared to the existing COVID-19 antivirals. So we need to have also coordinated system of vaccine and antiviral trials, so that we can modify our strategy and pick the best weapon by a coordinated way of the trials, and fair and equitable system of vaccine and antiviral deployments. As I said earlier, you cannot beat COVID-19 or any other microorganism by working alone in your own national border. With this, I will thank you for your time and will be happy to answer any questions you may have later.
Dr. Ashgar. Dr. Ashgar, thank you very much for that, addressing that issue. A very masterful presentation. I have learnt that resistance is the hobgoblin to antivirals, and I'm sure we've all learnt a new description there. But you have very wisely pointed out that it's not a clinical solution to a public health problem. The solution should come from public health to solve these stockpiling issues at the present time. So thank you very much for your presentation against stockpiling. And also thank you very much, Professor Smith, for your presentation for stockpiling. Of course, David started off from the wider perspective of talking about medical stockpiling, the importance of PPE and the bigger picture, in addition to antivirals. But above all, and what we learned from stockpiling of oseltamivir in 2009 was that unless you have the systems in place, then all the systems and mechanisms in place, that you cannot distribute it to the places where it's needed. So thank you very much, everyone. And I think that we are going to have the outcome of quiz number 2. Has the quiz number 2 been?
I think we need to. Yep, I think we need to ask the question. So if we could have the second quiz up on the screen. Thank you very much. And if people could respond to that, and then we will show the results of that in due course, because we're going to have to curtail things a little bit. So once this quiz once people have responded, then we're going to start preparing for the next session.